that started in May 2020. It's been nearly 1.5 years. It's been a community of practice that was set up to foster exchange and collaboration among several research organizations that were concurrently working on the multiple impacts of the pandemic in India. Uh, Overall, we've had over 60 member organizations. We operate both on email as well as on Slack, which is this WhatsApp-like workspace. All of these members, their projects you can see on our web platform, www.corenet.in, where you'll get a sense of the kind of projects, geographies, and themes that different organizations are working on. At the same time, every few weeks, we've been able to organize coffee hours such as this one, where one member or a few members share and reflect on their practice. You'd be able to see a whole bunch of them on our YouTube channel. You can just look for CORE Net Coffee Hour on YouTube and you'll find more than 20 of them online. At the same time, in 2021, we also put together the first CORE Net conference that included plenaries and showcases that covered multiple impacts of COVID-19 in that past year. So that was hopefully a good public resource. Also, we're putting together the next conference in April 2022, where we aim to capture not just thematic insights, but also cross-cutting issues and be able to foreground human stories of how, not just how the pandemic has affected us, but how we've seen great examples of individuals and communities really coming together to demonstrate resilience in amazing ways. The plan is to organize these four plenaries. The first one's on health system resilience, the second one on citizen-led resilience, inequalities and exclusion, and then research to policy adaptations. We'll be sharing a communication on this soon, so keep an eye out on your inboxes. For the moment, we'll be doing this coffee hour, which, as you know, is an informal conversation between organizations, part of the network. And the intention is for you to share with us whatever you'd like to discuss. So in case if you have an idea, please reach out to me or write to this email address. For this coffee hour, we'll be talking about the vaccine story in India and how we've seen the story really evolve over the past several months, and talk about what we see as sort of key issues or reasons for lower demand, particularly in the initial days, and how that's sort of changed and evolved now. This deck would have not been possible without the great support of many, many CORE Net members. Some of you are already here, but you know who you are. So thank you very much for helping us put this together. What we'll go through really is a quick timeline of events, just for everyone's information. We'll share some numbers on vaccine rollout and where we stand. Also discuss some early challenges around uptake, and then see what are potential sort of success stories that we already see unfold in front of us. We then have a few key questions that we'd like to discuss, but please note that this is quite a lot of information to go through. Ayushi and I will try our best to wrap it up by about 4:30, so we get a good 30 minutes to discuss, but we'll probably take a call closer to the end of the hour, in case if we feel like all of us need a follow-up conversation to that and we need more time to really discuss, we'd be open and keen to do that if you are all on board. As this slide suggested, like there's about 13 studies from the member network that we looked at. We'd organized them based on just when they had happened. So the earliest are from around February, when early sort of organizations like IDFC were already looking at vaccine communications and what kind of like needs are emergent from there. So February, and then later on, actually this NCAR study that ended in Jan. Then there's, of course, the second wave period, which is April, where, of course, for the first time while vaccines were accessible, this was also the big sort of wave where one sort of saw the pandemic sort of take over all of us in a big way. And then following that, there have been a range of studies from April all the way to October. I will be sharing this study with you all at the end of this. So you'll have time to go through this. There's also an appendix that has more information in it. So you'll have access to all of this information. Before we begin, we'd like to highlight that this is indeed a quick overview intended really for the purposes of discussion. Because these studies were organized and conducted by multiple partners across different states, across different timelines, it would really be unfair to think of this as a comprehensive synthesis or analysis. So please keep that in mind, that all of this is really bits and pieces of the story that we think we've tried to make sense of and we've put together. And this by no means, there's lots of information that we just don't have. And so these are not claims that we're making very, very confidently. So just a quick timeline from March 20th, 24th in 2020, when the first lockdown was imposed. Uh, it took us several months until when, I mean, several months when, of course, the vaccines were getting developed, but by 2nd Jan, India approved the 2 vaccines. There was a mass campaign to start vaccines for people above 60, healthcare and frontline workers. In a few months, of course, the Sputnik vaccine was also in place. Uh, then by 1st May, the eligibility also extended, so more and more people in the population could get the vaccine. By May, however, also there was the interval period that got shifted from 4 weeks to 12 to 16 weeks, if you remember, which became like a point of contention because lots of people who had taken the first dose then were just curious or not sure about when they had to take the second one or when they were due. At the same time, by fall, we saw a great sort of increase, not just in terms of numbers, but also campaigns got more and more strong. By October 21st, for example, India crosses the 1st billion mark. By November, the government launched the Har Ghar Dastak campaign, which we think had a significant impact in what we see today. And then early developments from this year include the vaccines now being open to children above the age of between 15 and 18, and then now booster shots. And we think that these two are really topics of conversation that we should be having as we go forward and think about how we maximize the uptake. Also, just wanted to add this parallel timeline of other events that one sees over the past 2 years, right? So as soon as the lockdown happened, of course, we remember the migrant crisis, and how early on social scientists figured that this is going to have far-reaching impacts on not just the economy, but also society, and will change how not just elderly, but also young people, women, and all kinds of vulnerable populations are going to get deeply affected. One does see that while there was a full year of impact, then by April 2021, we were all over again, like inundated by not just immense loss and grief, but also in a position where we had to make sense quickly of just where we were at. And we saw several sort of efforts happen, not just at the systems level, but also among communities, etc. And as we go on, while there were several success stories that also one started to see, we recognize that in the past 2 years, it's also had a deep impact on both the economy, on livelihoods, and on education, and so on and so forth. So we know that this will be far-reaching, but several of these also shaped the way people saw both COVID-19 as it got closer and closer, and also their relationship with the vaccine. So far, the country's had over 1.6 billion doses that have been administered. We see now that the male to female ratio is improving. We'll speak about this in a bit more detail. And if you look at this, which is really the vaccine progress among adult populations across 15 states, which is from January. Thank you, Shantanu, for this. That there is states like Madhya Pradesh and Gujarat that see a nearly like 100% uptake of the first dose and very close following up of both the doses, which is the blue. There's, of course, some states where you see this figure being relatively low right now, and lots of states are now working towards the second dose. But there is also this plateauing that one sees closer to January. And this will be a conversation to keep having, particularly as we now move to younger populations as well as booster doses. So these are sort of open-ended questions that we'll also speak about. However, these and like these, we want to also, as we speak about them, we also want to talk about initial hesitancies or initial challenges around uptake. And for this, we had studies that went from February to October, and this gives us a window into people's relationship with both the pandemic or COVID-19 as well as the vaccine. What we've done is looked at about 12, 13 studies, and which were done in a period of Feb to October. So you'll have to keep in mind that this is not the most updated information, but this is rich data that we have from the past few months. That we've bucketed now under these four that include general vaccine perception, health concerns, affordability and access barriers, as well as social factors. And we've done a really quick sort of overview and presented in this format where you can see the range of reasons that one begins to see around people's skepticism towards the vaccine or other challenges. So where on the general vaccine perception side, there is, of course, bits about information and waiting and watching, while health concerns are about health risks and side effects and comorbidities. Yeah, what I'll do is quickly pass it on to my colleague Ayushi, who can take us through some of these, and I will come back to quickly summarize after that. Over to Ayushi.
Great, thank you for that, Rohan. So as he mentioned, while we were going through these studies, there were four main buckets that stood out. The first one was around the perception of the vaccine that was based on the information available to the people, the trust that people felt, and the behaviors of others that really also impacted their own behaviors. So before the second wave, there was low knowledge of the vaccine, but we saw that during as well as after the second wave, this really changed, where one study suggested that 54% of the respondents were very well informed and 28% were moderately informed. The trust was of two types: the trust in the vaccine as well as trust in the government that we saw. So there was high misconception and mistrust of the COVID-19 vaccine initially, stemming from a lot of hearsay and misinformation. And whereas in cases of mistrust in the government, there were some states that showed a lack of trust in government like Punjab, whereas some other states that showed more trusting, they were more trusting of the government like Karnataka before the second wave. But one study by Satwa Piramaswastha suggested that the level of confidence in both vaccine as well as public health system really improved over time. The third point here was on watchful behavior. And initially, the virus was seen as this urban phenomenon, an urban disease. But post the second wave and during the second wave, we see that the virus, the disease kept getting closer to the people, it kept getting closer to home. And people showed a watchful behavior, and they wanted to wait and watch and see the effects of the vaccine on the other people. They were not willing to get vaccinated before seeing its outcomes on their friends and their relatives who had gotten vaccinated. And one report by UNICEF suggested that among those who were not sure of taking the vaccine, more than 1/3 wanted to wait and see. We've also collated some community voices that you will see here in this slide. Rohan, if we can move to the next slide. Here, the second bucket was around the health concerns that people had. So there was a range of both short-term as well as medium-term health concerns. The first one was in fear of side effects, where this was quite common from the vaccine, as was seen right after the second wave, which eventually actually declined. And there was also recognition that the vaccine prevents serious illnesses. People were also concerned about the unintended consequences of the vaccine, including some long-term impacts on fertility, immunity, among others. And one study by Inclusion Economics also showed that those who were hesitant, they cited some extreme side effects, like 69% of those respondents were afraid that the vaccine would cause death, and 30% were concerned about the side effects of the vaccines. Along with this, there were also stories of adverse events following immunization, where the news of some people dying right after taking the vaccine had also increased the fear of death among the people. The third point here, while health concerns formed one aspect under this, there was also the perception of low risk of COVID-19 itself, and particularly among the rural populations, the personal risk perceptions of COVID-19 was low, which they attributed initially to factors such as healthy living or the village environment or a sense of safety because of COVID-appropriate behaviors and a lot more home remedies that they were using around that time. Post the second wave, there was also an overall declining trend in this risk perception in the following months. And one UNICEF study suggested the vaccine uptake was actually not correlated to risk perception in months after the second wave. If we go to the next slide again, here are some community voices across reports that came up and that kind of spoke to all the points in the above slide. Going to the third bucket, and this was more on some of the supply side issues that people spoke about. There was access and affordability barrier. There was unavailability of vaccine, which was cited as a reason before the second wave, and some people were willing to get their families vaccinated, even if it was only if it was available for free. When asked about their willingness after the second wave, they had similar sentiments, but people were largely not willing to pay a subsidized price for the vaccine. And also we saw that the fear of side effects was seen as an opportunity cost where people missed days at work or were unable to conduct household work, and that impacted the willingness to get vaccinated. There were also some access to vaccination facility issues where there was limited availability of vaccine centers, especially in rural areas. There was also a travel time, travel cost, and waiting time that made it inconvenient for people to get the vaccines. And a few people also reported that there was a lot of worry about the possibility of catching virus in the process of traveling, waiting, and getting vaccinated. Lastly, here there was also some issues around access to booking slot, where maybe internet was not available or people did not have access to smartphones. But even in cases where infrastructure was available, people were not always digitally literate to use the platform. Again, we have some community voices that speak to the points above. And finally, the fourth bucket was around the range of social factors that came up. These social factors were seen to disprivilege the agency of women and young persons in decision making. And it was a common case to see with women that they had limited agency in making decisions of whether to get vaccinated or not. And in a lot of cases, their husbands and the family elders were making these decisions for them. Similarly, for young adults, for young people, the family elders were again making those decisions. And by September, however, this narrative was shifted a little where they said that my family and friends have also taken the vaccine, and hence that became a factor that actually positively influenced the people's choices to take the vaccine. And finally, some people also spoke about how if their questions were answered, then they would be willing to get vaccinated. Over to you, Rohan.
Great, thanks, Ayushi. Thanks for this. So just a few other slices that we thought would be useful to bring back to this discussion. The first one was around women, particularly, and early on in about July and August, it was seen, it was claimed that particularly women were disadvantaged in this entire vaccine game because of the reasons that Ayushi already shared, but these included bits about information, misconceptions, health concerns, mobility, access. However, it seems like a lot has happened in this space. Over 10 states now report, in fact, a positive vaccine uptake gender ratio. For example, the district of Samastipur is one where 3 days ago, about 115 women in comparison to 100 men have gotten vaccinated. However, and we'll talk a little bit about this later, it seems like districts such as Central Delhi, Gurgaon, and Noida show really negative sort of vaccine uptake ratios. For example, Gurgaon with 62 women upon 100 men. Also, specifically with women, there was limited information, it kept changing, and several misconceptions that had an impact, particularly on vaccines for menstruating, pregnant, and lactating women, which could have been a reason for limited uptake. This is my own cousin who was pregnant in the middle of the lockdown and told me about how she had to wait 6 weeks after she delivered to get her first shot, and she remembers that not a lot of that clear information was available. And also, this is a story from a healthcare worker who themselves were not sure about whether the vaccine was safe for menstruating women and didn't want to give adverse kind of advice. However, in this, we also did see, even before November, several like interesting success stories. The first one, for example, is the cluster vaccination strategy, where already in UP they were going block by block. And then this 2.0 model came where they went from the block to the village level, and the villages were sort of categorized in three categories based on just the levels of vaccination doses. And then the villages that had over 95% were proven to be COVID safe or COVID secure villages. And then they would honor the village and honor the headman. And then it became like this conversation around pride, and how does one get more and more vaccinations in place. At the same time, Ashas and Anganwadi workers were then sort of sent from door to door to speak with people who may be hesitant and so on. And this seems like really interesting models that were presented. At the same time, even other sort of collaborative efforts, such as the India COVID Action Collab, also did the Vaccine for Everyone campaign, where webinars were organized. And particularly, this speaks to the other social factors where people said that they may be interested but had clarifying questions. And especially spaces like this, where someone could spend time with hesitant populations, was very useful. Some of this seems to be a consequence of what you see right now, where it's quite stark that the difference between villages and states. So some of these cities, sorry, like Mumbai, Calcutta, Delhi, have relatively low female jab ratio, and if you see, like their overall state ratios, they seem to be much better. And it seems like villages have consequently over the past few months done better. And some of this seems to be, of course, these individual success stories, but also importantly the Har Ghar Dastak campaign, which was from the 3rd to the 30th of November. And here you see a big sort of transformation, where rather than saying that, hey, this is a vaccine, this is good, why don't you do it for yourself? Here, the conversation changes to vaccines for all and vaccines for free, and that vaccine is insured for you. And this is, of course, for both people who had missed not just their first, but also their second dose. So it seems like, and particularly because it was door to door, it sort of addressed all of these access and affordability barriers that Ayushi was speaking about earlier. However, I mean, it would be really useful for research to look at what specific districts sort of were targeted, and what, the success of the program. So we don't have enough information on this so far. At the same time, this, we feel like just studying this campaign a bit more will give us great clues into just still seeing what hesitant populations are like, what are general perceptions and health concerns that remain in unvaccinated populations, as well as the role that particularly community influencers and frontline workers have been able to play. And as we've seen, like now the game is all about just these wait and watch populations, right? Like how is one able to speak with them and sort of make some of these conversations happen? At the same time, while some of these sort of campaigns exist, one also sees that there's a range of incentives now, for taking the vaccine and participating back in everyday life. Some of this you see at your own workplaces, where for all kinds of travel, for work now, people need to come back with double vaccination certificates. But at the same time, in Tamil Nadu, for example, it's the cinema hall which you can't enter without a double vaccination certificate. And it seems like a really interesting story. At the same time, while there is improving access and emergent evidence and efficacy, I think, what we want to say is that there's still these underlying reasons of hesitancy that would be really useful to constantly be looking out for, and particularly in specific populations and what works for them. On the one hand, you have Dr. Satvik, who says that we have to be careful in seeing hesitancy for what it is, and not take a moral high ground against anti-vaxxers. And this sort of shows up particularly when we start to make mandates like not allowing people without a certificate for the Republic Day parade, which can be challenging, but also from a user perspective, to think about what are incentives and disincentives for taking the vaccine, right? Like even the promise of it, where we have this one voice which says that even though you take the vaccine, you still continue to mask, you have to socially distance, and you still may get the virus, and you hope that it's not that bad, right? Does this seem like a great sort of set of incentives, or how does one communicate this in ways that that will be effective to populations that still don't see the value of this. So this is just broad summary. We wanted to leave us with a few questions to discuss, and we can take them one by one, and we can always just come back to them. So the first one is around underlying reasons, as I was sharing, particularly around local and regional success stories. What can we learn from them? What have been sort of perceptions around the vaccine, particularly in specialized groups, such as women? The second one is around specific populations, and are there correlations between how they take to the COVID vaccine as against general immunizations? Are there particular ways in which those sort of schemes or strategies have worked? What changes, specifically with the COVID vaccine? The third piece is on second dose hesitancy, and is it really hesitancy, or are these just issues around access or convenience one needs to solve? Particularly as it's assumed that once the first vaccine is taken, the hesitancy is over, and it's just that maybe the time is not right, or people feel like it's still not valuable enough. So just unpacking those would be valuable. Then there's a question around booster doses. What do we need to know better in order to be able to roll them out, particularly now among younger populations from 15 to 18, as the conversation moves towards schools being the sites of intervention? How will permissions work? What will be the conversation around ethics and so on for that? How will one make this mandatory is a big question. And finally, the big question we all want to think about is around vaccines as ideal sort of health-seeking behavior, right? And as evidence is coming up around the efficacy and so on, what kind of research might inform communications and programs that encourage health-seeking behavior among populations? And we feel like this is the bigger sort of lesson to draw from the entire sort of piece that we're going through right now. So yeah, this is the list of questions. We've already spoken a mouthful. We're at 4:31. And maybe what I'll do is invite Dr. Shantanu to share his insights, and anyone else from the community who'd like to reflect on these questions. Um, and yeah, just in case if there are any clarifying questions too. So, but over to Shantanu.
Hi, Rohan and Aisha. Thanks. That was a very nice summary of all the studies and overall the overview of vaccination coverage situation and the challenges we have faced over the last 1 year or so. So I don't have much to add, but just if possible, can I share a couple of slides, Rohan?
Yes, Shantanu, for sure. The floor is yours. I will have to add you as co-host. I'm so sorry. I'll just do that.
No, that's okay. Yeah.
Yeah.
Can you see my screen?
Yes.
Yeah. Yeah, so basically, where do we stand if we just try to evaluate our progress in terms of vaccination coverage? So I just took data till 31st December because I think from various news reports, we know that the government has had set the target of vaccinating all adults by December 31st. So which implies approximately if the 944 million is the total number of adults, so about 1,900 million doses were supposed to be administered by 31st December. So, but what we achieved is around 1,400 million or slightly higher than that. So, so about 400 million doses short on our target. So that's the sort of progress, which I think reasonably good progress given the we have seen at different phases, we have seen level of hesitancy which varies which varied over time, which varied across states, and also we have seen supply challenges when the vaccination vaccination drive was open for all the age groups. We have seen that in May, particularly, there were several challenges in terms of supply of vaccines, and even if it was open to all, everyone was not able to actually get the vaccine. And we have seen that some states, particularly Tamil Nadu and Punjab, having a constantly higher level of vaccine hesitancy compared to some other states, and in most states we have seen a reduction in vaccine hesitancy during wave 2 or around wave 2 because of the severity. It has demonstrated that probably had an impact on the vaccine uptake and reduced hesitancy. So overall, I would say it's a good progress. And as I mentioned, like you can see, this is the daily doses of vaccination, and it's a 7-day moving average. And we have seen, as I mentioned, that in May, it actually dipped down significantly. And then again, it picked up the pace quite nicely. But again, October, November, we see some slowing down. That might have hampered our progress. I'm not sure about the reason why it happened in October and November. And the campaign that Rohan mentioned, I mean, this is a graph from October, at end of October. And you see the difference in first and second dose coverage in states like Madhya Pradesh. It was quite large. I think Madhya Pradesh has the highest gap between the first dose coverage and second dose coverage. But after perhaps that campaign was launched, we see a very different picture. I mean, in Madhya Pradesh, it's actually the lowest gap we have seen till I think December data. So that shows that the campaign had huge impact in certain states. So that's a good thing. Yeah. So that's just all few points I wanted to highlight. That's all for now.
Great. Great. Thanks so much, Shantanu. This was super insightful. And particularly the last one where, yeah, like the bits that you
Yeah, I
really
was also
highlight for
wondering
particularly
how it
states. Yes.
happened. The this case was very curious.
Right. Right. Anyone else? I see we also have Dr. Angela Chaudhary, who was also, I mean, yeah, featured on the deck as part of the COVID Action Collaborative. Angela, any thoughts or insights?
No, I'm just amazed to see, like you, the last slide, that the campaign actually had some results. And I'm wondering what happened to the other states, or if there's something else that happened in MP. This is a good lesson for us to see whether campaign is one route or there are other routes happening there.
Yeah, that's a good one. I think we'll also check ourselves. I guess we'll take the we'll study the graphs. But anyone else who knows in the group, just in case if anyone knows an inside story from MP and what happened there, please feel free to unmute yourself and speak. Okay. I don't see any hands up, so maybe it's just a question that we'll park for the moment and come back to it with some more work on this, I guess. Yeah, and see if any other member has any thoughts, reflections on any of these questions. Great.
Rohan, can I share a response
please.
to some of the local success stories?
Yes, please.
Sorry for my voice. This is my third day of COVID, so I do have a blocked nose. But in terms of local success stories, we have stories on reaching some of the special populations. And I say special because we just use the word marginalized a lot. But I also see that you spoke about menstruating pregnant and lactating women, which is a big no, because we all behave strangely when it comes to pregnant and lactating women. Um, but and as educated as we are can be, but just for that story on trans, but also sex worker population, people who live with HIV, those who are on dialysis. There are many like tribal and Adivasi groups, etc. Um, just broadly summarizing all our lessons, because I won't go into the details and we can have a different discussion on that, but it's actually a people-centered approach. Vaccinations and COVID and health, let's look at that, is not even the top 5 of people's priority until it hits people's livelihoods, social safety, their own personal safety, and their family security, right? And when I mean safety, it's not just safety from violence, but it's also from nutrition, their daily meal, the next day, but also violence. And so when we spoke, we worked with the tribal and Adivasi groups, and they had a thing to say. We don't have a safe water. We don't have good water. We don't have lights. We don't have roads. Why are you coming and giving us these jabs? Trans people had huge reservations. One is across all the groups, it's a general distrust of the government. So I would say a recipe in reaching that group is by reaching their leaders and trusted stewards of their community. That's one ingredient to a success story. To identify who that is. There were many imams that we worked with to be able to get into those groups who are siloed from the rest of the general population. So that is one definite ingredient to a success story. The second is the people-centered approach. What do people need the most? So for the trans people, they definitely needed to know that alcohol and hormone replacement therapy and their interactions. We reached them through their leaders. We told them through their leaders there would be people there, professionals who will answer all your questions, one. Two, there will also be food rations available because most of the trans people from those communities had sex work and begging as livelihoods, which are all taken away because of the lockdown. And therefore, big healthy portions of rations and other essentials were very important to them. So they came in droves, and that's the picture that you have.
Right.
We also have sex workers. We have people living with HIV. We just have to know what is their that needle and really utilize that needle and work closely with the primary health facilities, because the PHC staff are actually often blind to these populations who are invisible to them. So if you bring them along and there is a newly formed establishment of presence, later it's a little bit of trust, and then you leave the phone number, you actually foster a relationship that will go beyond COVID moving on. So just some ingredients there for a success story. Thanks.
Great. Great. Thanks so much, Dr. Angela. This was indeed very useful, and particularly two bits that I found interesting. One is, of course, like the actual bits of doing, but then also communicating it successfully and who to communicate to would be also interesting. But as you were speaking, I also see Akshay, who's here from Brahmbani, and Harsh from Inclusion Economics, and I was wondering if you both had any inputs on particularly migrant workers, and particularly in the past few months, if you've figured that there have been success stories in also that, if there's anything you'd like to share with us. And maybe as I give you a moment to think, I was also thinking, I also see some of our old friends. There's Radhika, Deepika, Divya, and for a lot of the first year, we discussed challenges and opportunities also for frontline workers. So it'll also be interesting to hear from you all if there's any new bits that you are working on or uncovering, both from the point of view of the interests of the frontline workers themselves, as well as the populations that they are sort of working with. Because as it seems like all of us have postulated, their role in sort of creating systems resilience becomes more and more valuable, right? So first on to Akshay and Harsh, if you have anything to share, and then Deepika, Radhika, Divya. Sorry, I'm just pointing, randomly nominating. I'm not cruel.
Yeah, so I think I just have one thing to mention here, and it might sound very unusual. So I think while you mentioned that research where we found out that around 69% people who had hesitancy were afraid of death. So within, as part of the same research, we also found out that people were getting like sort of forced vaccination around May, June in Chhattisgarh. So what forced vaccination here means that they were not being allowed to take their PDS rations. So they were only being given their rations if they were vaccinated. And while in the starting, it was like a forced way of vaccinating people, but then what it led to was like a sort of like trust in people that, okay, these people have been vaccinated, but nothing happened to them. So of course, not the best way it happened, but then there is some questions of ethics there, but then something of this sort did occur in the ground, and then it resulted in some sort of like removal of hesitancy.
Thank you for sharing. Yeah, this was useful and a good contrast to, I guess, keep in mind. As well. Thank you. Anyone else? Akshay, Radhika, Divya, Divika. Yeah, please unmute yourself and speak.
I'm happy to, because you particularly asked us to come in on the frontline health worker piece. So I also want to say that I sort of agree with a lot of points that have been discussed on the human-centered approach and all of that. And we are following a lot of those elements in the geographies where we are working in vaccination right now. And even the coercion or coercive element of not receiving entitlements and so on, and how that has had an impact. In fact, just adding to that further, we've also received cases where we're talking about elements around hidden refusals, where people either postpone or delay or procrastinate as in when people come to mobilize them, or there are other workarounds that they've figured out to receive vaccination on paper, but not really taking the vaccine to bypass a lot of this coercion and fear. There is a lot of literature that we're putting together and writing thought pieces, which is more focused on how this whole fear-induced incentivization to take vaccine is going to have a sunset point, wherein people, it as a stick will stop working, because we're not talking about vaccination sort of ending at the second dose, right? There is a booster dose that might come up and so on. And so this is an evolving situation, and the repercussions of this kind of fear-induced uptake is probably going to be really detrimental. Also, in many cases where there is hesitancy and there is, bordering resistance, also comes from the lack of trust in the system in itself, especially for minority communities and vulnerable populations. And there, this kind of a fear-induced tactic is going to further create detrimental issues, and that's going to start sort of percolating probably into other outreach services too. So I think those are some of the important points to already start looking at, and we're hoping to put together cases and so on from the work that we are doing. On particularly the frontline health workers strengthening piece, we recently had a chance to work in Andhra for frontline health workers and their mental health. And I think that has been a great eye-opening space, because there's also an assumption when you talk about frontline health workers that a lot of mental health stressors do come from the kind of work stress that they have in times of COVID. But honestly, a lot of our dialogue and work with them reveal that there are multifold factors that are playing out here. There are many social elements to it. There are gender norms that are playing out for these women, and what they've internalized their role to be in their home spaces, and not being able to do it sort of creates much more stress and guilt. This is some work that Radhika and I sort of did together in Andhra, which has been interesting. So when one thinks about strengthening of frontline health workers, I think that's a very critical space to work in. And we are hoping to sort of further some of these learnings into recommendations for the Andhra government with our partners there. So that's probably one piece that seemed relevant. Thanks.
Great. Thank you. Thanks for sharing both of these pieces, Divya. And I mean, it'd be great to learn from you more. And Angela's also added that there's a differentiation between barriers and hesitancy that needs to be made, and negative and positive incentives. And in their explorations or studies, or in everyone's, actually, we need to tackle these comprehensively. Yeah. So as we also build this out, I guess, for more studies on hesitancy, these are pieces that one needs to think about, particularly bits about coercion and how, surely, as Divya suggests, and as Angela was saying, that maybe human centricity, if we just keep foregrounding that, that would be the way to sort of find out underlying causes. Yeah.
Absolutely. And hi, Angela, just to say the Andhra work that we are doing in COVID vaccination is also happening with CAC. So we're working very closely on vaccination with CAC. And
Yeah,
I think
definitely.
I think moving away from the language of hesitancy to inequitable access to vaccines is probably a better, and barriers to vaccination instead is better. And when we're thinking about hesitancy going forward, that's the kind of language that we're taking in. So absolutely, yeah.
Great, thank you. Speaking of language, we also have Alka from UNICEF, who's been doing communications for really long and shared with us also the study that UNICEF did to inform their communications. If I could request Alka to share your thoughts on this, and particularly around how one communicates about hesitancy, and whether it's time, as we are suggesting, to step away from it and really think about it as barriers to access. Alka?
Thanks, Rohan, for pointing out to me and asking me to share my thoughts. I couldn't agree more with this differential approach and human-centered centricity in communication around vaccine uptake. I think that's a given. And the more I'm reminded of the diffusion of innovation, the typical bell curve, you know, the early adopters, and we've reached the large majority. And then there has to be, in any program, people who will not take it up just for various reasons. It could be access, it could be doubts, it could be various reasons. And I think we need, definitely, I agree with your third question. And I was actually thinking, are we seeking out information on inequitable access around the second dose? And I really like this way of approaching it. Why are we presuming that people are hesitant? There are, there could be very valid reasons that communication can overcome. And in that space, there were two thoughts that came to mind. One is, of course, understanding better the reasons, the fears, and putting them out. I think what's happening is that we are not really communicating about menstruation and vaccination, lactation and vaccination, these hormone therapy and vaccination. These are big issues in people's lives, and there isn't enough information about it. So one of the biggest roles that communication can play is to actually acknowledging the fact that we don't know enough, because it is an evolving situation. The vaccine is not tried and tested forever and forever. It was just developed last year. So, so that is, even acknowledging that will get us the trust that we need from people to come forward and take the vaccine. So one is on acknowledging and communicating about the hesitancy issues, and some of these. I have a colleague who actually had a delayed period after her vaccination shot, and then she started to find out, hey, what happened? Did I suddenly get pregnant? What I mean, so there wasn't enough information out there, and you really have to seek it. If we were to just put it up front, that would be great. And the second is the method, and I really think that we have to revisit the way that we are, or shall we say, strengthen the way that we are communicating about the vaccine. I don't think now there is enough conversations on the vaccine itself. There was a point in time when we did the studies and we said 80%, 90% of the people were getting information from television and so on and so forth. And now it's dropped to a much lower level, about 74%, the last assessment that we did. So there isn't enough communication about it. People have moved on. So if you've moved on, then you need to keep, if there are elements that are important, then we need to just make sure that we continue to engage around that. And in that space, I think it's important to look at real stories, real instances, not informative, not at the cognitive level, but more at the emotional level, and in the way that we do our communication. One is the content of what we are communicating, and the second is the way that we are packaging our communication. If we could base that on real stories, and we're just going to enter into some conversation around that. We are planning some story-based content for promoting vaccination as an organization. So that's the second thought that I have. And very valid question. Some of these I'm going to take into the new study that we're doing some offline social listening via telephone on conversations that are happening not online, but in the offline spaces. And I think specifically asking about the second dose is something that we should be doing now. We were earlier in the speed of just everybody gets vaccinated, and now a little bit more around that. So, and just some reflections. Thanks.
Thank you, Alka. This was super valuable. Yeah, I think certainly, both of these pieces about just what specific challenges are in getting to that, because I think we've all heard the big story too much, and we've just gotten more used to it. But I think also what you said about the second piece of how now COVID is part of our lives. It's been 2 years that we've sort of lived through this, and I remember 4 months ago when we did the conversation in the coffee hour, we were talking about how there are these waves when this stuff becomes important and less important, and how does one just make it more part of our everyday. I think really valuable. So thank you. Deepika, I see you've left a comment. So Deepika says, along the lines of potential impact of the vaccine, in another collective, quite a number of women are sharing how their periods experience has changed even after getting the COVID vaccine, and the evidence along those lines also needs to be strengthened. Yeah, which certainly speaks to Alka's point that particularly more details as we gather about stuff or information as it's emerging, not just from the stories, but from anecdotal evidence, it would be useful to just at least bring these together in one place. Just speaking about information and misinformation, I also see Nandita who's here, and if I could just call upon Nandita, just because we've always found the work that she does at Factly and Facebook is super interesting, and Nandita has been working on this project around misinformation about COVID. Nandita, in case if there's anything interesting here, what is the new stuff that you're coming across, and what's keeping you curious?
Yeah. Hi, Rohan. Thank you for pointing that out. So when we talk about vaccine hesitancy, and like other speakers have been discussing on the usage of the terminology itself, there are a lot of things, underlying reasons for this refusal, hesitancy, or any other terminology that we might use. one of the biggest challenges that we are trying to address is the misinformation aspect, wherein we are trying to see how local WhatsApp messages to social media messages to how these things have been affecting people. And like Ms. Alka was also mentioning, that communication does play a very important role. And when we were in our project, we are only looking at, say, from because we were working with Facebook, we were looking at how to curb that problem from that point of view, and how we can actually, talk about, just a second, how Facebook has been dealing with the misinformation problem. But when it comes to closer groups like WhatsApp, we are still far away from a solution as to how to curb this kind of messaging, and why do people actually share these kinds of messages. I mean, in terms of, who are the ones creating these messages, this misinformation, and what are the types of misinformation that actually go around, and especially with respect to vaccine refusal, hesitancy, what kind of messages play well with urban versus rural crowds, and demographically how messaging is different. We have been trying to look at these aspects, some of the aspects that we are currently working on, and we'll soon get back to you on how to do it. As Ms. Divya was also mentioning, that AP, they're working in the state of Andhra Pradesh to try and look at what are the barriers that people have been facing with respect to second dose, booster dose, and other things as well. So we are also looking at different qualifiers for what is actually the barrier behind this refusal, or for that matter, what exactly is the term that we can use for different regions as well, because it's not a uniform hesitancy across the country that we are seeing, and definitely not like something we see in the West, where there are active anti-vaxxers. So the case here is a little different. And yeah, a lot of things are absolutely true, like the agency for women, for instance, they do not have the same agency as that of the men or the elders of the family. So we were actually in touch with doctors from Kerala, who have been trying to debunk these family WhatsApp groups where the elders have been pushing the rest of the family members to not take up the vaccine, and how we can actually correct those messages, and how the doctors have been doing, community live groups or that calls or something where they can actually educate people. So yeah, it's the problem statement that we are right now working on is how to do it within the communities, language wise, especially on closed network groups, and how do we crack that. We are also trying to partner with state governments to try and understand what else can be done and how differently things can be done. So yeah, some of the very pertinent questions here, and hopefully going forward, we'll be able to come back with some of our research as well. Thank you.
Great. Thanks so much, Nandita. Yeah, some very interesting takeaways. I see we're already 3 minutes over time. So I will try to do a quick summary and say thank you to all of you. This has been super useful for us trying to put this together and then have this conversation with you all. So thank you for your support. I mean, it does seem like particularly understanding what specific state governments have been doing well is one important thing to look at. But as Nandita was just saying, a lot of this sort of nests within communities and their own sort of deep-seated beliefs, and it will be useful to arrive at that, make distinctions between barriers and hesitancy, and incentives and influences, and also what Alka was talking about, of how like this sort of exists both in online and offline spaces. So particularly unpacking behaviors in both of those realms might be increasingly valuable. And finally, I think the big takeaway for all of us is that this information is sort of going beyond just factual right and wrong and yes and no, but really entering into the realm of stories that we want to tell and believe in. And I guess that's the realm in which all of us will be moving this communications work as we go ahead. So thanks again. So many thanks to everyone who's able to join us for this session, but also all the members, researchers who've been able to communicate and contribute to this deck. Also, big thank you to Shantanu for guiding us as we went along in this journey. So thank you, Shantanu. And yeah, thank you for your time. What we'll do is publish the recording for this video as well as share the slide deck with you all soon. And yeah, we'll take it from there, and we'll also share with you more around the CORE Net conference that should be coming up soon.